Good evening, everyone. Welcome to Coping with Side Effects of Breast Cancer Treatment. My name is Angela Papalia. I'm the Assistant Director at the Adelphi, New York Statewide Breast Cancer Hotline and Support Program. Welcome to a wonderful program this evening. For those of you that may be joining us for the first time, we'd like to welcome you to the program. The Adelphi New York Statewide Program has been in existence for 45 years, serving New Yorkers with free psychosocial support services to all those who have been touched by breast cancer. We provide comprehensive counseling services in both English and Spanish, as well as specially tailored support groups for those who are going through varying stages of a breast cancer diagnosis and journey. We offer a multitude of educational forums such as this, and we welcome you to our program this evening. If you'd like to have more information about our program, please visit our website after this program and learn more about our statewide hotline, which is the oldest breast cancer hotline in the country, staffed by incredibly dedicated, inspirational volunteers, all of whom are breast cancer survivors themselves. And they're always available to provide a listening ear, referrals, resources, and support. As our social work staff is available to provide any type of supportive counseling and referral services that you may need, in addition to navigation services throughout your journey. Our program this evening will run approximately for 1 hour and is being recorded. Throughout the presentation this evening, our esteemed colleague, Dr. Douglas Marks, will be offering people the opportunity to enter into the chat any questions that you may have regarding the content in his presentation. As we go through the program, we will try to answer questions accordingly, but if we don't have the opportunity to ask your question, there will be information provided at the end to reach out to Dr. Marks at a later time. This evening, I have the privilege of welcoming Dr. Douglas Marks, a medical oncologist from NYU Langone Perlmutter Cancer Center, here tonight at the Adelphi Breast Cancer Program. Dr. Marks specializes in the treatment of breast cancer and provides his patients with the most up-to-date and innovative oncological care. An accomplished researcher and clinical trial investigator, Dr. Marks's research has been published in numerous peer-reviewed journals, and his research has been presented across the United States time and again. Please join me in welcoming Dr. Douglas Marks this evening on his presentation, Coping with Side Effects of Breast Cancer Treatment. Thank you so much, Dr. Marks, for joining us this evening.
Sure. Thank you, Angela, for having me and for everyone for attending. Like Angela said, I want to go through a fair amount of content, but would welcome any questions that could be put into the chat, and we could take breaks at periods of time in the presentation to go through them. Just to confirm, my slides are still showing, right?
Correct, yes.
Okay. So we'll call this talk Coping with the Side Effects of Breast Cancer Treatment. And I think why that's so important is because, for the majority of patients with breast cancer, treatment is not, just for several months, but it is often for many months and sometimes years. And managing side effects to improve quality of life is very important, as well as also managing side effects so that patients can stay on their therapies and not have treatment interruptions that we can avoid. These are my disclosures. These are companies that I've worked with on clinical trials or that are advising on different drugs that are in development. Today, we're not going to talk about any of this. We're going to talk about side effects. So, breaking down side effects by treatment, I sort of put them into 3 different categories. There are the side effects that are very specific and unique sometimes to the hormonal endocrine therapies that we give. These are the therapies that reduce estrogen levels and as a result have been a very unique set of side effects that that can affect patients for the years that they're on treatment. Sometimes these improve over time, sometimes they do not, and coping and addressing these side effects are very important. Also, side effects of chemotherapy. These often are quite different than endocrine therapy type side effects, although there is some overlap. These side effects, can sometimes be quite debilitating and require additional medications to address them. And then targeted therapies, which are like a second category, somewhere in between hormone therapy and chemotherapy. in that they are not simply working by just lowering estrogen levels or blocking estrogen, but rather do affect cells that are dividing, can have some chemotherapy-like side effects, often to a lesser degree, but they also can have very unique side effects that are different than either of the other two groups. So to start with endocrine therapy, I think it's very important to say that endocrine therapy makes up the most important therapy for the majority of women with breast cancer. The most common type of breast cancer is estrogen receptor positive, HER2 negative breast cancer, which makes up about 60 to 65% of women diagnoses and men as well. Actually, men are even more likely when they rarely get breast cancer to get this type. So this is the most common type of breast cancer. And as a result, the most common type of breast cancer treatment is endocrine therapy. And it's an important part of treatment for both women who have early stage disease, which means that the breast cancer is diagnosed when it's in the breast or the lymph nodes but hasn't traveled, as well as also important for women whose breast cancer has left the breast with stage 4 or advanced cancer. There are different types of endocrine therapies, one of which is called tamoxifen, the one that's been around for a very long time, less popular than it used to be, but still has a role for certain women. Newer drugs called SERDs, one of which is called elacestrant. These are drugs that, instead of blocking estrogen, they target the protein that estrogen finds in the cell to allow it to work, and they break down the receptor protein. Aromatase inhibitors, these are very common. Three of them are letrozole, exemestane, and anastrozole, are pretty well known to probably many in the group here. These are drugs that lower the estrogen level, and they've been a very important part of treatment since early 2000s, late 1990s. And then gonadal suppression, which is the turning off of ovaries, typically by an injection, although this can be accomplished by surgery as well. These drugs, they can have a very dramatic impact on a patient's quality of life, and they're also extremely effective. Breaking down to sort of the most common that if you were to look up any of these drugs, you would find pages of side effects, and I think it's important to recognize that some of these side effects may not always be linked to the drug themselves, but other drugs that patients are receiving or other aspects of their general health. But there are certainly a number of very important side effects with these medications. And I'm sort of outlining some of the most common or the most important to not forget. And then I highlighted in red the ones that I'll sort of talk about in a little bit more detail. So hot flashes and night sweats are very common with endocrine therapy. They're amongst the most common side effect. I describe this to my patients as saying it can feel like going through a second menopause. And that's because with, for example, aromatase inhibitors, you're lowering an estrogen level that may be around, mid-20s, mid to high 20s, down to, less than 10. And that is an adjustment that is not quite as dramatic as the adjustment that occurs at menopause, but is a meaningful adjustment in going from low to even lower. And so I'll sometimes describe this as a mini menopause. To which patients always tell me, well, I already went through menopause, and I tell them, I know this would be a second mini menopause maybe, in about 30 to 40% of people who have hot flashes. Arthralgias, not arthritis, but a stiffness syndrome that patients can describe, often worse in the morning or after being sedentary or seated for a while. It feels like the joints are stiff and takes a while for them to get moving. This symptom can sometimes be hard to tell apart from arthritis, but I think that one of the major differences that I alert patients to is that unlike arthritis, where patients often complain a lot at the end of the day because it's like bone on bone rubbing and their knees kill them after walking for a while, etc. These drugs tend to cause a stiffness syndrome, which when you actually use them, they feel better. So patients will say, actually, after I start moving, I feel better. Actually, at the end of the day, I feel better than at the beginning of the day. Of course, it's a little complicated since you have both arthritis and arthralgias, and it's a little bit of both, but it's a stiffness syndrome. It's not an arthritis, and it's a very important side effect. These medications can also cause a reduction in the bone density and put some people from osteopenia to osteoporosis. It's quite rare that they take patients who have good bone density and make them develop osteoporosis. It's much more common that patients who already have osteopenia are at greater risk for osteoporosis. There may be some cardiovascular risks, very small increase in cardiovascular risks, particularly with the aromatase inhibitors. Blood clot risk, especially with tamoxifen, it's less than 1%, about a 0.7% risk of blood clots. But very important that you let patients know that if they have any leg swelling or pain in their calves or shortness of breath, that they let us know if they're on this drug because it needs to be worked up promptly. And then also very important, some of the gynecologic structures are affected by the decrease in estrogen, and there can be vaginal dryness and also sexual dysfunction or sexual changes that can occur with these medications. Um, so big way of sort of addressing this. There's some kind of cornerstones to addressing these side effects. Exercise is very important for the stiffness of the joints. Lifestyle modification, weight loss can help with the joint stiffness as well. Non-hormonal therapies that I'll talk about. These are medications that could be used to help sort of combat the hot flash side effects. Bone strengthening medications to reduce bone loss. And then again, I should have said hot flashes. There's a host of different types of medications that could be used, including antidepressants that used at different doses sometimes can also help for hot flashes, or other drugs like oxybutylene, which was originally approved for urinary frequency, but works very well at reducing hot flashes. So going through them one at a time, some of the most common hot flashes, I tell patients in terms of lifestyle, there are some patients that will note certain triggers like spicy foods or caffeine. So obviously, if you notice these are your triggers, you can reduce this. Simple things like layering your clothing so that if you're out and about and you're having a hot flash, you're not uncomfortable because you can't sort of unlayer, that you're able to unlayer in a public place and still feel appropriate. That can help. Using your air conditioner more, it's obvious, but this can also help. Then of course there are pharmacologic interventions. Oxybutylene, like I mentioned, certain of the antidepressants. Paroxetine or venlafaxine are most common. Gabapentin, and then sometimes a drug called clonidine. But some of these drugs with the pharmacologic ones, it's very specific to the patient. For example, clonidine can help with hot flashes, but it also is a blood pressure medication. So it would not be a good choice for someone who has, very good blood pressure or borderline low blood pressure to use that medication, whereas the other ones would potentially be appropriate. So not all these drugs are interchangeable, and they should be selected based on what the patient is already taking and making sure they don't interact or conflict with their existing meds, and as well as what other medical problems the patient has. And then another sort of non-pharmacologic approach that I found helpful is acupuncture. Acupuncture works for a number of side effects from endocrine therapies, primarily and best well studied for the joint stiffness. But patients do, and have reported improvement in hot flashes with acupuncture. Gynecologic dryness and sexual dysfunction. I think this sometimes is one that is sort of put to the side just because it's sort of not necessarily felt that it's immediately bothersome to the patient, but of course it is. And these are important to address. Usually, if it's mostly a dryness phenotype, I will discuss with patients using hyaluronic acid type moisturizers. These are not lubricants that are only used during sex, but these are suppositories. A number of brands makes them. One of them is called Replens, and essentially the suppository is used every 3 days or so, and it actually just moisturizes the tissue. So it's not just for sexual intimacy; it's as a baseline moisturizer. And then on top of that, lubricants can be used as well. And this can help reduce, the moisturizer part of it can reduce skin tears as well. So it could be used with or without lubricants. In very specific situations, especially for women with hormone receptor negative breast cancer, or hormone receptor positive breast cancer that is distant from their diagnosis, using short amounts of vaginal estrogen can be helpful. Obviously, we are not looking to raise the estrogen level in the patient's body. So, we're not looking to give oral estrogen therapy. So vaginal estrogen therapy, most studies indicate that it only very minimally, if at all, raises the estrogen level in the blood. So in select patients after they've tried the non-hormonal approach, that can be reasonable. There are also some drugs that kind of work like they sort of partially block and partially stimulate estrogen, and so they stimulate estrogen a little bit less in the tissue that we think is involved in breast cancer cells, but maybe slightly more in the gynecologic tract. So these are called alternative SERMs, and these can be considered. And then there are some non-pharmacologic treatments, including pelvic floor physical therapy, where you can increase blood flow potentially by increasing the muscles in the pelvic floor. And then arthralgias. This is a very important one. This probably comprises about 30 to 40% of patients will describe this stiffness syndrome when they start on this medication. And arthralgias, there are a host of non-pharmacologic approaches: yoga, tai chi, PT, acupuncture. These have really been quite helpful, and also just routine exercise. Not just once a week, though. Patients have to work out 3 to 4 times a week, usually, to notice a difference. So I'll say like 150 minutes a day, or 4 times a week, 30 minutes a time, something like that, to get people going. Then, of course, there are pharmacologic medications. Usually, patients start with Aleve or Advil, but if those are not enough, also topical versions. Topical versions of Aleve, like Voltaren gel, where if it's just affecting 1 or 2 joints, it might be reasonable to offer that to patients. Obviously, they feel that their whole back is stiff in the morning, and all their hands are stiff and their feet are stiff. You're not going to recommend covering their bodies in topical creams. That's when an oral medication is indicated. So NSAIDs, Aleve, Advil, Voltaren gel, certain types of medications that work on the way that our body perceives pain, one of which is called Cymbalta or duloxetine. These are called SNRIs. These are sometimes used also as antidepressants or anti-anxiety medications, but I tell patients all the time that they've been shown to work in numerous settings, and they even have approvals, some of them for knee pain after knee surgery. So, even though sometimes it can be hard to explain to a patient why their medication could also be used as an antidepressant, and that they should still trust you that it might also help their joints, I'll often point to that as a reason why to consider it. So Cymbalta or duloxetine is often recommended if a patient has multiple joint involvement. There is some data that suggests that having higher levels of vitamin D, or certainly not low levels, may be helpful, at least at reducing the discomfort. So, we do check vitamin D levels, or their primary doctor, if we don't, does that. Swapping sometimes the one pill from another pill. We don't exactly know why this always works. It doesn't always work, to be honest, but in about a third of patients, just swapping from one pill to another pill in the same category. For example, if someone's on an anastrozole, offering them exemestane, this can help a subset of patients start to feel better. And so maybe it's just their brain resetting to a new medication, or maybe the way the chemistry works in their body is slightly different, but that's an approach that is pretty low intensity and doesn't increase the total amount of pills a patient takes. So patients often don't mind doing a pill swap. And then sometimes switching to tamoxifen, if it's appropriate, could be reasonable. Tamoxifen does have some less joint aches issues, although it does have some other side effects, that are generally considered less appealing than joint aches. But if joint aches are the patient's major problem, and none of these other approaches work, changing to tamoxifen may be reasonable. And even doing a temporary drug holiday, which can give you a little bit of a break and also help make sure everything is what you think it is. For example, if it's hard to determine whether a patient has rheumatoid arthritis and they're also having joint pain, and it's hard to know whether the pain that they're having is mainly due to their rheumatoid arthritis versus your pill that you started them on, giving them a holiday of around 4 weeks or 2 to 4 weeks can help patients sort of understand what the role of the medication may be playing. If they start to feel better after taking a few weeks off the medication, it really suggests that the medication is probably at least a big part of the culprit. And then, of course, you then have to convince the patient to go back on the medication. So I usually tell patients before I do that this is an investigation, but I know you may feel better, but we still need to work together to try to make it work after we're done. So the last one in this category I'm talking about is osteoporosis and bone fracture risk. When on treatment with endocrine therapy, patients get DEXA testing, and if their bone density is low, and it doesn't need to meet osteoporosis, sometimes just having significant osteopenia, which we define as like a T-score less than -2.0, will prompt discussions about addressing patients' bone density. Lifestyle factors that are important: weight-bearing exercise. So while cardio is great for your overall health and being thin, weight-bearing exercise is very important as well for increasing your metabolism, but also for potentially preserving and maybe in some patients strengthening their bone. So strength training, weight bearing, avoiding smoking, avoiding alcohol, having a well-balanced diet with protein, getting enough calcium in your diet. These are the most important lifestyle factors that we can focus on. In terms of pharmacologic factors, more popular drugs include bisphosphonates. This one's popular one's often called Zometa, denosumab, also known as Prolia, obviously vitamin D and calcium supplements, and in some patients actually protecting their ovaries so that their ovaries recover earlier can be helpful as well. All right, that was a little bit of a whirlwind through endocrine therapy. So maybe we could take a break now, take a peek in the chat and see if any questions came on to, from what we've been discussing before we sort of move on. Let's see. Yes.
There was some positive feedback regarding some of the interventions that you had mentioned, Dr. Marks. There was a question about mood changes as a side effect from the aromatase inhibitors.
Definitely, mood changes can occur. I tell patients that, it's not like everyone becomes depressed or necessarily becomes anxious from it, but it could just even be as simple as having more mood fluctuations as a patient acclimates. But there are some patients that do develop anxiety or actually depression. When I'm talking with the patient, first thing I'm trying to figure out is if they're sort of in an adjustment period and whether they're having some subtle symptoms that are likely to improve or whether they're actually having symptoms that are really debilitating, interrupting their life, preventing them from doing activities, preventing them from enjoying life. Then that's actually someone who sometimes needs to go on a medication for their mood or anxiety to help them manage it. But what a lot of patients go through is more like a fluctuation in their mood, and that fluctuation in their mood can often level out. And so just providing them with reassurance that it's normal, that, they might be watching, Chicago Blue and then cry at the end, and, because it's something that they usually wouldn't care about. And then this is a story, the patient told me the story, I thought it was so on point. And then go to Cheesecake Factory afterwards for dinner, because they still love their life and love their kids and love their family. That's not a major depressive disorder. That is an adjustment period to the medication, and it usually improves. But there are some people that become, very affected by the medication and then, need psychological, guidance as well from social work and from their oncologist, and also sometimes the medication. Someone mentioned Veoza here. I think Veoza is a very reasonable choice. Veoza, you have to be a little bit careful of liver function tests need to be monitored on Veoza. Some of the other medications I mentioned don't quite have that effect. Veoza is also a little bit new to the scene, so but it's non-hormonal, and I do have patients that are helped by Veoza. I love acupuncture. Someone wrote I love acupuncture. I would say that can be very helpful. And duloxetine also can be very helpful. Duloxetine Cymbalta I mentioned can be helpful for joint pains, and that's going to come up again later when we talk about chemotherapy for neuropathy. And this patient is noted that it helped with their chest wall pain, post-mastectomy pain, which is a similar kind of neuropathic pain. And the last question is, will I discuss long-term effects of radiation such as fibrosis? If we have time at the end, maybe. That's definitely not my area of expertise. I can tell you that I'm not a radiation oncologist, but they are looking at some new compounds, some caffeine creams, and also other types of creams that could be used to actually prevent radiation fibrosis. And then after fibrosis, physical therapy can be helpful. I'm not as, the status of where those are right now is not exactly what I do day in, day out, but it is a field that is looking to improve on itself. And one thing that radiation oncologists are doing very differently is they're shortening their courses of radiation and tailoring it much more specific to the amount of disease a patient has, and that has dramatically reduced the incidence of fibrosis or the extent of fibrosis. Okay, so I'll move on to targeted therapies now. So targeted therapies play critical roles in all subtypes of breast cancer in both the adjuvant and advanced setting. So again, adjuvant means in patients who have early stage breast cancer, which hasn't spread outside the breast or the lymph nodes, and advanced means stage 4 setting. There are a number of targeted therapies. The most popular ones include CDK4/6 inhibitors. These are now used for estrogen receptor positive, HER2 negative breast cancer, and also in some estrogen receptor positive, HER2 positive patients. They can be used in the early stage setting or the advanced setting. mTOR inhibitors. This is a drug called everolimus, is the most popular one. PI3K inhibitors, of which there are 2 now, alpelisib and inavolisib, and there's many in development as well. AKT inhibitors, one of them is called capivasertib. PARP inhibitors, olaparib and talazoparib, and the anti-HER2 therapies, as well as immunotherapy like Keytruda or pembrolizumab. So these are a unique category of a sort of catch-all of all therapies that sort of fall in between the hormonal axis and not quite meeting the criteria for chemotherapy. They can have unique side effects based on the type of targeted therapy they are. For HER2 positive patients who are on anti-HER2 therapy, they are watched very carefully for cardiotoxicity with echocardiograms. Diarrhea can happen with a number of our CDK inhibitors, particularly Verzenio or abemaciclib, and also with a drug called neratinib is very common. Neutropenia is very popular with CDK inhibitors in general. Fatigue with these medications, liver toxicity can occur. Pneumonitis, which is lung inflammation, can occur with CDK inhibitors to a lesser degree, but very famously to a rare but serious degree with the drug called TDXD. Rashes and nail bed changes, high blood glucose, and the development of autoimmune disease. So I thought I would pick off a couple of these here and just go through them. I know there are a number of different strategies for each of these, but cancer-related fatigue, I think, is an issue that can really be debilitating for patients. And we have probably the least available to help us in this setting, but we do have important approaches. And what I always tell patients that is hard to wrap their mind around is that exercise has always been found to reduce cancer fatigue when looked at rigorously. It's the same amount of exercise as before for we talked about with joint discomfort, at least 4 to 5 times a week. Aerobic and resistance training, yoga and Tai Chi also have been looked at and have seen promising. And then some cognitive-based activities, mindfulness-based stress reduction, which is a sort of meditation type-based stress reduction strategy. Cognitive behavioral therapy with a psychologist, where you reinforce certain cognitive approaches to managing your schedule and managing your sleep and managing everything that can help support reduction in fatigue. Nutritional optimization. Sometimes there can be patients who are really not eating very healthy. Obviously eating healthy is very important. Having a high protein diet. Not getting all your sugar from simple sugar. These are things that can be done to improve your nutritional status. Also, you want to look at the patient and make sure they don't have any reversible cause of fatigue that you could potentially address based on either another medical problem that they've had all along, or a medical problem that they developed while on treatment or as they got older. And so, for example, if a patient has anemia because they have iron deficiency, and maybe that wasn't really bothering them before, it was a mild case, but in the context of these medications, they're feeling more fatigued, then you can optimize their anemia by potentially giving them iron infusion or giving them iron supplements. Same thing if there's thyroid dysfunction, being on thyroid supplements. Dose reducing the medication if the medication is a CDK inhibitor and is associated with particularly low blood counts. And then pharmacologic, in patients that are really not able to get any sleep, and you've tried all the lifestyle factors, sleep aids, and antidepressants can sometimes help patients who are depressed if depression is felt to be the cause of their fatigue, which sometimes it is. Sometimes you'll talk to a patient about fatigue and it'll sound differently than regular fatigue, and you'll realize that they also just don't have interest in doing things, and they're occasionally tearful when they shouldn't be, and then every once in a while it's like a pseudo fatigue, it's more of depression, and then you treat their depression and their fatigue improves. Hyperglycemia, high blood glucose, obviously getting a nutritionist involved and being on a low glycemic diet, rich in fiber, reducing simple sugars. Metformin can be helpful as a first-line medication often when patients have high blood glucose due to their medications, to prevent them from becoming dehydrated or having chronic sequelae of high sugars. There are more than just metformin that are available. Usually oncologists start with metformin, but if the sugar is still difficult to control, we'll either take a dose reduction or take a delay if the blood sugar is very high, while we involve an endocrinologist to use one of the other alternative medications for addressing and decreasing a patient's blood sugar. Diarrhea. Sometimes diarrhea doesn't need to be so significant in terms of number to really cause a lot of problems. We grade diarrhea in oncology based on how many numbers of stool a patient has a day, but it doesn't take that many stools a day to make someone quite uncomfortable. So, we call grade 3 diarrhea when someone has more than 7 bowel movements over their baseline a day, and that's a real reason to lower someone's dose, grade 3 diarrhea. But if someone is having 3 or 4 loose bowel movements a day and they're sort of not able to control when they happen, that can be very debilitating to a patient. So prophylactic antidiarrheals, taking Imodium, in advance of going outside, if it's mostly when you leave the house at certain times, having Imodium on hand can be helpful. Sometimes focusing on foods that are associated with it, even though we know the drugs are driving the diarrhea, that does not mean that there can't be dietary interventions that can make the diarrhea more manageable. Intermittently using a brat diet when you're having a lot of stool, like a more mild diet when you're having the peak of diarrhea, can be helpful. avoiding dairy in patients who are a little bit lactose intolerant who then develop chemo-associated diarrhea. Strict dairy avoidance can be helpful. And then, of course, hydration. And then dose reduction, like I mentioned, when needed. Okay, maybe we'll take another break here and go into the chat and see.
There seems to be some questioning regarding intake of soy, Dr. Marks. Can you speak to that on the safety of having soy-based products?
Yeah. So I think that this, this comment about soy. So a couple of things. It's very important to eat protein, especially when you're on chemotherapy, because you don't want to lose muscle mass. So that's very true. Sometimes using a supplement shake with protein in it is okay, but we don't want to replace all of our diet with supplement shakes, because that doesn't really help with your digestion because everything is liquid. So we really want to eat whole food as much as we can. That's high, protein-rich diet is very important on chemo. And I tell patients a low-fat diet. So soy, I don't think that we have any convincing evidence that having, normal amounts of soy, particularly from natural sources, is a problem. Meaning, like having a piece of tofu on top of, a stir-fry dish, that's not a lot of soy in terms of density. Soy lecithin in some of the processed soys, where there's just a very high amount of soy in a very small amount of food, that's where there's been some concerns that this may raise sort of the phytoestrogen levels in a patient's body. The good news, I guess, is that these foods are rarely ever healthy. So it's rarely ever that you're giving up eating something that you should really be eating anyway. But like classically, they are found, like someone mentioned, veggie burgers, but also found at very high levels in like a lot of snack foods, like graham crackers and animal crackers, and all this kind of like junk, crisps and that kind of stuff. So I think that soy, whole soy, natural soy in regular amount as part of one's diet is nothing that needs to be worried about. Processed soy, may be associated with slightly higher risk of developing higher estrogen levels, but also are generally not very healthy. So it's not much to give those up in terms of your health anyway. Someone asked, would sex help or hurt a woman going through cancer treatments? When a patient is on chemotherapy, they need to pay attention to their body. They may not, some women who are on chemotherapy feel that they're comfortable having sex. Others feel, that it's not really that appealing to them right immediately around the moment of getting chemotherapy. What we do advise, however, though, is it's very important that patients have, certainly if they need to use contraception, if they could potentially get pregnant because they're, for obvious reasons, because chemotherapy can be very toxic at certain time points in pregnancy development. But also, we do recommend, most oncologists recommend that the male partner wear a condom while on chemotherapy in case there's any vaginal secretion of the chemotherapy. In terms of hurting the woman, I think it depends a little bit on how physically they're feeling on treatment. Like it's not something, if they're having a lot of vaginal dryness and they're having pain with sexual intercourse, then that should be optimized before they continue, because it may be, cause some, might be feeling that there's some micro trauma going on. But it's not like having sex is contraindicated or not allowed when a patient's on treatment. If the patient is doing well on their treatment and not having, issues with their blood counts and not having infections, then sexual intercourse is permitted, and is allowed. It's just, we would recommend a condom, a type of barrier method if they're having sex with a man. Okay. Let me see what else is here. After 14 rounds of Kadcycla, approximately how long does the Kadcycla stay in my system? So there's like two things that I think are being important by this question. One is like how long literally is there Kadcycla in your system? And after about 6 to 8 weeks, probably there's almost no Kadcycla in your system, or very, very little if at all. But that doesn't mean that the side effects from the treatment are finished. So sometimes I'll describe chemotherapy as kind of like a fire for patients, in the sense that like the fire may be quick on and off. The drugs are in your body and out of your body pretty quickly. Even shorter than Kadcycline, chemotherapy is out of your body quicker. But the effect of chemotherapy and the rebuilding of the body that happens afterwards, can take time, meaning that it can take a while for anemia to fully resolve. It can take a while for the energy level to get better, and it's very variable. Chemo brain is not something that has a specific end date. They did look at one study which showed that about 2 years, almost everyone cited that their chemo brain was fully resolved. But that's really not been my experience, that I can tell a patient that their chemo brain will be gone by, improved by 3 months. But usually there's a gradual, steady improvement in that symptom over time. It can take a while. Whereas there are some symptoms that are much more quickly to resolve. For example, nausea and diarrhea. Very quickly after chemotherapy is finished, even just before the next cycle, it's quite unusual to have, any more diarrhea. Whereas there are these side effects that have a more long-term effect on the body, like, for example, neuropathy. Neuropathy can take months to improve. It usually is gradually continues to improve, but unlike diarrhea and nausea, it doesn't have that quick on and off. It takes a while to recover. And so when you're seeing a patient and they're asking you about when their neuropathy is going to be better, I always tell them, it could be months, and that's normal. Okay. With that, we'll move on to the chemotherapy section. So chemotherapy is the backbone of many therapeutic regimens for a majority of HER2 positive and triple negative breast cancer regimens. It's also important for high risk ER positive breast cancer patients when they're, when, for example, it's involving the lymph nodes or involving their breast and has high oncotype scores or something of that nature, or in women who have advanced or stage 4 ER positive HER2 negative breast cancer after they've gone through endocrine therapies. There are a number of different chemotherapies, and anthracyclines, taxanes, platinums, and capecitabine are amongst them. I did sort of break them out into sort of subsets to try to give some clarity on individual ones a bit that people may be familiar with. So most common side effects, nausea and vomiting, very common, particularly with ones that are highly emetogenic. Doxorubicin or anthracyclines. This is the adriamycin medication. This is part of a regimen called ACT. It's very important that you give a lot of anti-nausea medications when you give this medication. Myelosuppression or neutropenia, peripheral neuropathies, particularly for taxanes and platinums. Hold on one second, I apologize. Alopecia, hair loss, mucositis and stomatitis, hand-foot syndrome, where there's a rash that has a predisposition for the hands and the feet, heart toxicity, and brain fog or cognitive impairment. Most big overarching ways that we address this, we can give medications to boost the white cells. We can give cold claps for preventing hair loss, neuropathy prevention with cold claps and compression gloves in some patients that are highly motivated. Particularly, they're not going to do the cold caps, cold hands, cold feet can be very uncomfortable. Anti-nausea medications, and then of course, choosing our patients very carefully that we give drugs that have heart risk too. A little more detail, peripheral neuropathy, ways that we can address this by lowering the dose or changing the dose schedule. I often give Taxol, which is a popular medication, on a weekly versus 3-weekly basis because it has less neuropathy in general at weekly dosing. So that's sort of something I do. But if I have a patient that wanted it for 3 weeks for their schedule and then had this neuropathy, that'd be one way I would interfere, try to address it, and then I could also lower the dose if required. Cymbalta, that medication that we mentioned before, duloxetine, also can be very helpful for neuropathic pain. Gabapentin, and then cryotherapy or compression gloves can help prevent neuropathy from worsening. Alopecia, hair loss. We have a number of ways of cooling one's scalp. There's different systems that could be used, the machines, the cold caps that patients put on themselves. These caps have a variable effectiveness depending on which treatment regimen, meaning that there are some chemotherapy regimens where these caps work in only about 10 to 20% of people, like ACT, for example. And then there are other chemo regimens like TC, where patients, maybe 60 to 70% of patients can say that they feel really good about the protection that they got from hair loss and that they didn't even need a wig, or any kind of hair covering. So These caps can be helpful. Their success rate depends on the chemotherapy that they're being given with. For some chemotherapies, they're much more effective than others. Rogaine can help hair grow back quickly after treatment. And so if someone's hair is coming in and be really proactive, Rogaine can be helpful for that. And then, of course, for our patients that would like to, we can also, do hair prosthetics, wigs, and sort of allow their hair to come back after their treatment is complete. Hand-foot syndrome. This is a very unique side effect that is famous with a number of chemos, but one of them is Xeloda. And Xeloda is a very popular chemotherapy for patients with advanced breast cancer or early stage triple negative breast cancer after neoadjuvant therapy. And one way of improving on or reducing the hand-foot syndrome is by giving the dosing slightly different, giving it maybe every other week instead of 2 weeks on, 1 week off. And also sometimes by decreasing the dose for flat rate dosing. Other things that can be done are using preventative gels called Voltaren gel, which can help prevent hand-foot syndrome, moisturizing incessantly. Urea creams that are really thick creams, almost used for burns as a preventative, can be helpful. I tell patients that if they're having significant symptoms, that actually I recommend that they put this urea cream on their hands before they watch TV at nighttime or before whatever activity, before they read, and then put on gloves, like plastic gloves that keep that moisture in, and just let that moisture absorb into their hands, for an hour or so, until they almost prune, to try to get that moisture in deep, and then they take it off so that they really can get the moisturizer in there deep. And then sometimes a topical steroid cream can be helpful. Oops, okay. All right, with that, that's my last side effects slide on chemotherapy. We can go back to our chat now. We've got some more in the chat.
We do. We have quite a few questions, Dr. Marks, regarding the compression gloves with respect to the neuropathy. Someone was discussing using the cold gloves and socks during Taxol and Herceptin, questioning about compression gloves. Is that something that they should add to that regimen, as well as what types of compression gloves to utilize? Any suggestions?
Yeah. So I don't usually recommend cooling and compression. The cooling and compression have been looked at separately, and both seem to be helpful. But I do think that for a patient who is uncomfortable with the cooling, compression is a better option. Or if they're doing a cold cap on their head, it's almost torture to imagine doing cold capping and cold head, cold hands, cold feet. So compression gloves are not like a specific brand that I endorse, but many of them are the ones that you see as arthritis compression gloves. Those are the ones that I usually recommend the patients get. And, of course, you have to make sure it's not cutting off the circulation, that your fingers are not turning blue, but they should be tight. And that can be a helpful approach to reducing. Now, the majority of medications we give in breast cancer, actually, the neuropathy is reversible. The issue is that's not the case for everybody. And if someone, already has baseline neuropathy, or if they have a job, for example, like other patients that are, accomplished, violinists, for example, or something. That was one of my patients. And so, for her, I was telling her that it's most likely going to go away afterwards, which is the truth, of course. But at the same time, for her, there's very little room for error because her whole livelihood is based on her ability to play her instrument. So, for her, we were very proactive. She did, cooling gloves initially, and then she did the compression gloves afterwards. So they can be used either approach. The idea of what it is that you're reducing the chemotherapy from going to the tips of the fingers and the tips of the toes. And similar to a cold cap that freezes the scalp so the chemo doesn't go to the hair follicles as much, this can reduce some of the neuropathic symptoms.
With respect to the gloves, if I can just ask a question that comes up quite often, much like the lymphedema garments, patients are encouraged to go get fitted by a certified lymphedema specialist. Is that the same frame of mind in terms of when patients are interested in compression gloves? Is there someone specifically that they should seek out to ensure that those compression garments are not too tight, or what's been your experience with that?
I haven't had the success with anyone being able to get fitted for compression gloves.
Okay.
In a way, there is a way of measuring the exact pressure that a compression glove exerts, and you use a tool to do that. That's not something that really people do in practice. if you look at how people cool their hands, it's also very variable. At some institutions, people are putting their hands on ice packs, and others they're using cool gel packs. Um, you know, I don't think we know that any or are totally, some people use mittens and some people use regular gloves. Um, I think all these approaches help a bit. And that between that and also making sure you dose reduce if it's getting to the point where a dose reduction is indicated, that's sort of a level of protection that you can add on top of it. But no, there's not, like, I haven't had anyone who's been able to get like the PSI measure, the actual pressure in their glove, for example.
Thank you.
Let me just take a look here. These were the, yeah, regarding lymphedema risk. Safe to use those regarding lymphedema risk. I'm not exactly sure what this means, but you can use, yes, you can use compression gloves even if you've had lymph node procedures on that side of your body. Very good. Okay. Let me just take a look back at some of these. So someone asked, is Cadcycla chemo or a targeted therapy? It is a chemotherapy being delivered in a targeted manner. For the purposes of this talk, I think it really fits more into the targeted therapy category because the side effects are so much different for Cadcycla than traditional chemotherapy. Patients don't get, typically low blood counts, like except for platelets can sometimes go down a little bit, but they don't get low white count. They don't usually have terrible nausea. They can get neuropathy because there's a chemo attached to that called M-tanzine. So it falls somewhere in the middle. It's a targeted therapy, but it's not a conventional chemotherapy, nor is it a hormonal therapy. So it has overlapping toxicities. Cadcycla also doesn't have hair loss, so it doesn't really fit. Because it's targeted, it fits more into a targeted therapy in my mind.
One of the things at the Adelphi Breast Cancer Program that we'd like to remind people is that if you are experiencing certain types of side effects based on your very specific chemotherapy and treatment regimen, we do have trained volunteers who are professionally supervised that staff the hotline. So it gives people an opportunity to talk to somebody that's actually had the same experience, because sometimes it really does help to speak with someone who's been there and has understand. And certainly we encourage patients always to refer back to their oncologists with their very specific and unique needs with respect to side effects.
Sure. Happy to answer any other questions that the group has. I think that that for me, when managing a patient's side effects, I first try to think about the likelihood that the side effect will improve on its own and how severe it is, because sometimes some of these side effects will get better with time with just a little bit of an intervention, maybe a Aleve or Advil, versus a patient that is really having a side effect that is sticky and pervasive, for which a new medication needs to be started, or sometimes a lifestyle modification approach like like acupuncture or something of that nature. So this is definitely not an easy part of the job, but it's a very important one. I've never been asked to give a talk about side effects before, so I was honored to. Usually we want to talk about the drugs or something of that nature, so it's kind of nice to talk about side effects because they're important as well.
We really do appreciate your expertise and your time, Dr. Marks. This is something that has really been affecting patients in various stages of their, their journey with breast cancer. And it's so varied, as you so eloquently shared this evening. And there was so much ground to cover, but you truly, really did. You not only did you give people access to you directly, which is always so much appreciated, but there are so many different strategies, perhaps, or different things to discuss with one's doctor if they are struggling with certain types of side effects. So we really do thank you so much for your participation this evening. Right. And since we do have Dr. Marks for another moment, if there's any final question that you would like to ask, please enter it in the chat now. Oh, people are very appreciative to hear about this part of the journey that's usually glossed over. So people are grateful. Lots of gratitude in the chat, Dr. Marks, for you and your expertise. And if patients would like to reach out to you or seek you and your team out, what's the best way to do so moving forward?
Sure. So, I see patients on Long Island and Manhattan. but I think I put my email address on my last slide, which you can share. Ultimately, it's not a great way to answer specific questions that a patient has, but it can help if someone would like me to sort of, help guide them, to a visit or something like that, or if it's something that's not specific about their health, then I can also help them. But my email address is on the slides too, and I'm happy to take any emails. Yes, so that's a good question. Do cardio effects diminish once Herceptin is stopped? They do, which is a little different than for other medications. Herceptin, the real risk of cardiotoxicity is while you're on the treatment, whereas some chemotherapies like doxorubicin, the risk is around 10 years afterwards, sometimes earlier, but a classic time would be like 10 years later, versus Herceptin, where the issue with the heart is really while you're on it, and then for a very brief period of time when you're off of it, while it's just leaving your system. So yes, the cardio effects diminish dramatically once Herceptin is stopped.
That's an important question. Just taking one last look. Oh, great. And there is a mention, Dr. Marks, anticipatory nausea, getting nauseous before the chemotherapy actually starts. Can you just speak to that for a moment?
Yes. So anticipatory nausea is, a very real thing, and the classic person who will describe it says the night before their chemotherapy, for example, they'll start to feel nauseous, and so what I will tell them to do is, of course, during their treatment, I'm giving them anti-nausea medications for most regimens if anyone's having any nausea, but that they should just take, as a preventative, a Zofran or Compazine or some medication of that nature the night before when they're, in preparation for the anticipatory nausea. And that can work very well. Because nausea is a feedback loop a little bit too. It's, you can have nausea that can be driven by stomach upset, but the majority of nausea is driven from directly the chemotherapy on the brain stem and the brain making you nauseous, or sometimes a little bit of that and then superimpose stress as well. So taking anti-nausea medication that works on that area of the brain, can help a patient, with their anticipatory nausea even before they get the chemotherapy.
Thank you.
What is overall? Yeah, I think that it's very important to keep in mind that for many patients with breast cancer, they're going to be cured of their breast cancer. So it's very important that you don't sort of impart on them that that's the only thing that matters in their health moving forward. Heart disease is very important contributor to women's mortality rates, still the driving factor, in our country. And so we really don't want to lose sight over the fact that lifestyle changes can really impact a patient's health. So, for example, sometimes these things are very linked. Like we have a fairly good amount of data that a pretty strict, if a patient's very motivated, that having a strict low-fat diet, so that's not a paleo or Atkins diet, that's like the opposite. A low-fat diet is like a South Beach diet or a plant-based diet that can reduce a patient's risk of developing breast cancer recurrence, particularly if they're estrogen receptor positive breast cancer. And so I do encourage patients that really want to maximize their risk reduction and lean into lifestyle to read about this and to consider a nutritionist. But basically the long and short of it is that you try to keep your calorie intake from fat below 20% of your daily calorie intake. So let's say you're supposed to have 2,000 calories a day, then that would be less than 200 calories a day from fat. So, these are ways that you can, that you can impact your risk with lifestyle. Certainly exercise reduces the risk, being thin in addition to having low fat improves the risk. There isn't, unfortunately, like a vitamin that I can recommend. It's not like, taking high doses of vitamin E will reduce one's breast cancer risk. We looked into some, baby aspirin, a few other things that really didn't necessarily lead to such exciting results. But having a low-fat diet, good exercise, and then also, drinking sparingly. So, and there was a Surgeon General report that came out about this recently too, that the heavy drinking, which I would call, more than 2 drinks a night, so over 14 drinks a week, that we've always known, is associated with increased breast cancer risk recurrence, and a meaningful amount. 1 drink a night was a little bit controversial, but most studies seem to suggest that it was associated with some increased risk, not to the same extent, but some, and recent data really has supported that. So I tell patients that really are everyone, you have to choose what you do in life to have a good life, and where you're going to impact take your impact. But if drinking is more of a special occasion thing than it is a daily thing, then that will reduce your risk of breast cancer recurrence. Doesn't mean you can never have wine at a wedding or anything like that, but it means that if you limit it to those events versus with dinner every night, you're probably the data suggests that you're reducing your risk more. Are there any side effects to Perjeta? Yeah, so Perjeta can have a small heart risk like Herceptin does, but Perjeta also can cause diarrhea more than the other ones do. So I've definitely had some patients where Perjeta really causes them to have a number of loose stools. The issue with these medications is that we don't have a dose reduction strategy for Perjeta. So lowering the dose of Perjeta is not really usually done. We don't know if it would really work as well, and it may not even change the diarrhea. So what we usually do in that situation is try to push the antidiarrheals. And then some patients that are on Perjeta but really don't need to be on Perjeta, which there are some people that are like that are probably didn't need to get Perjeta to begin with, but we were just giving it out of abundance of caution. In those patients, you would drop the Perjeta. But often with Imodium and Lamodal, sometimes that becomes manageable. The other thing is that sometimes you're giving Perjeta with chemotherapy for part of the treatment, and then that's when it's really tough. And then when they drop the chemo, the Perjeta's diarrhea becomes more mild. And so yeah, I would say the most common side effect of Perjeta, besides the small risk of heart issues, is diarrhea. And also rash. You can get a rash with it.
Dr. Marks, thank you again so much for this incredibly informative session, and again for you generously donating your time. We really do appreciate it on behalf of the Adelphi Breast Cancer Program and the whole community here. We certainly will share your last slide with everyone before we put up our evaluation. Would you be okay just pulling that up? Or if I can share it with all the attendees?
I'll put my email in the chat here for everyone.
That's perfect. Thank you. Thank you so much. And to all our attendees tonight, thank you again for taking the time to join us this evening. We hope you'll continue to join us and be a part of the Adelphi program. If you take a look in the chat, you'll see Dr. Mark's contact information as well as the evaluation. Please help us to continue to offer these programs free of charge by filling that out and helping to really shape these amazing forums such as this one this evening. And that does conclude our program this evening on coping with the side effects of breast cancer treatment. Dr. Marks, thank you so much for joining us. Right. Be well, everyone. Good night.